We're thrilled to see so many of you join us here today. You're among 1,800 urgent, critical, primary care, and other clinicians who registered for today's webinar. Welcome to you all. Joining us from Europe, Africa, the Americas, Oceania, and Asia. Good morning, good day, and evening to you. Welcome to our webinar on Pragmatic POCUS, Diagnosing Renal, Gallbladder, and Aortic Pathology. By delivering the ability to make a quicker and more accurate diagnosis at the bedside, the popularity of point-of-care ultrasound has grown dramatically. Today, it's used in the ER, ambulance, helicopters, private clinics, patient homes, too many places to name. Handheld POCUS is disrupting the urgent and primary care world by empowering healthcare practitioners to see and diagnose many patient conditions without needing additional testing. Quick and succinct answers enable clinicians to make the decisions that matter to patient lives while generating value for both them and their patients. Shortly, we'll introduce you to today's expert guest speaker, the fabulous Dr. Virginia Robinson. But first, it's my pleasure to introduce you to your host. Dr. Aron Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He now practices in a busy academic teaching hospital in Vancouver as an emergency physician. When he's not saving lives, Dr. Frankel serves as chairman of our Clarius Medical Advisory Board, helping deliver educational content like today's webinar, and also like our new Clarius Classroom, with now nearly 100 on-demand video tutorials available for on-demand learning. Dr. Frankel, welcome and over to you.
Thanks, Janez. It's good to be back. And today's topic about point-of-care ultrasound in primary and urgent and emergent care, it's a topic close to my heart. In doing the background research for today's webinar, we found some really interesting papers that I wanted to touch on kind of the state of affairs of point-of-care ultrasound use primarily in the primary care setting. And the first one I wanted to touch on was a systematic review of generalist performed point-of-care ultrasound. And there were a significant number of studies that found variable but generally low utilization of point of care among general practitioners and primary care providers. Although it seems that, as we know, it's been thoroughly established the use of point of care in emergency medicine in North America and increasingly in the rest of the world. And interestingly, the clinical studies really spanned across the entire spectrum of pretty much anything that us physicians and healthcare practitioners diagnose, covering heart, lungs, thorax, vessels, abdominal, obstetric organs, ocular, soft tissue, and musculoskeletal systems. And as we know that the studies found really generally high sensitivity or high specificity for most of the particular tests that were studied in these research papers. And in some cases, there's high total accuracy and superior to other more established diagnostic imaging modalities. And most interestingly to clinicians, I think, like us, is that the point-of-care ultrasound generally shows faster time to diagnosis and a change in management in a lot of studies. And this really mirrors our clinical experience of using this technology in our clinical care of patients. Another interesting study that's more specific in Switzerland to primary care actually found a surprising number. It seems like Switzerland is a pretty high adopter for point of care in the primary care setting. And this is based on billing data, suggesting that there is a revenue stream and value generating function of point of care ultrasound there. And up to about 50% of primary care physicians were using point of care ultrasound in their practice and completing a significant number of exams. Primarily, it was abdominal ultrasound that comprised almost 70% of the exams that were done in this study. And people generally really appreciate it and found that it expedited their care, again, of their patients in their practice. And lastly, there was a prospective observational study that I wanted to lastly highlight from the BMJ, which showed how the use of point of care ultrasound really changed in a significant number of cases the physician and the practitioner's diagnostic process and their certainty and their decision making and how they treated their patients. This study found that almost 10% of patients received a point of care ultrasound in their clinical course, and that the primary care providers who scanned, again, a variety of organs, over 100 different diagnoses could be identified on the point of care, with each scan taking 5 minutes or less to complete. And the ultrasound increased the confidence in the diagnosis in up to about 90% of patients. And interestingly, and most surprisingly, I think it really changed the diagnosis or management in 50% of patients, including a reduction in referrals to outside providers and a specific change in the treatment plan in about a quarter of the patients. So these are really powerful clinical impacts of this technology that's becoming more and more readily available. But to kind of see, we have an audience that's really spread internationally across the world and in different clinical practices. We sort of wanted to see what challenges you face as clinicians. Without the point of care, we're really restricted in the way we treat patients to our clinical exam, which is our 5 senses and our auscultation with the stethoscope. So if you have to rely on a clinical exam, which of the challenges have you faced recently, do you feel like in your experience? And please click all of the above that may have applied, so we can see that we're really on the same page about the challenges we face daily. Have you experienced too broad of a differential diagnosis on your patient and unable to really narrow it accurately with your clinical exam? Or we take our best guess as clinicians, that's our job, and sometimes we're wrong. And do you find that you've been frustrated or unfortunately reached a mistaken diagnosis? Have you had to refer patients to get more advanced diagnostic imaging that you feel like really delayed treatment and potentially did it result in ineffective treatment? Having to choose between some of the diagnoses can result in treatment that could even be harmful potentially. Have you experienced unclear progress, patients returning back to your practice for a second visit, third visit with a presumed diagnosis that maybe was wrong or the treatment is maybe ineffective? Or have you lost patients? They seek a second opinion, sometimes for advanced imaging or additional testing, and you never see them again. We hear this from some of our providers. So I want to give this just a couple seconds to leave the poll and then we'll close it. And let's go ahead and see where the results are. Yeah, and interestingly, too broad of a differential is probably the most likely thing that we all experience. And then it kind of trickles down into some of the secondary findings and secondary effects. And so we'll see soon with Dr. Robinson really leading us on how we can really narrow our differential diagnosis. And I think that's really the largest power of point of care ultrasound. And before we get there, we did have one other poll because some of the reviews suggested that up to 50% of primary care providers are using point of care ultrasound. We just want to know what's the spectrum of our participants today. And this is a really quick one. Do you use point of care ultrasound already daily? Do you use it occasionally? Are you contemplative and hoping that one day, soon, maybe with a bit of extra information, you'll be using point of care ultrasound? Or are you a non-believer and never will use point of care, in which case I wonder why you're at this webinar. Okay, we're gonna close this one out. Let's just see where we're at. Yeah, okay, so we already have almost half of us are occasional users. This is great. So people have some skills, they've had their hands on the probes, and we can get them a bit more information, we hope, and really advance people to the maybe daily users. That is excellent. So, we know what the challenges are, and so how do we overcome these challenges? The way is to improve our education and learning, and we're so happy we can't think of a better speaker to come to us today than Dr. Robinson. Virginia Robinson began her career working in the remote Cree community of Chisasibi in northern Quebec 25 years ago, and she subsequently spent several years working in a high-volume urban emergency department in Kitchener, Ontario. And at one time, a keen mountaineer, she served as the physician for the Canadian Everest team back in 2000. For the last 15 years, though, Virginia's been practicing maternity and emergency medicine in Fernie and Cranbrook in southeastern British Columbia. And she's an instructor for both the hands-on ultrasound course in emergency medicine and obstetrics, and presently leads the intelligent network for the point of care ultrasound project for the Rural Coordination Center of BC. Dr. Robinson, we're going to hand it over to you.
Great, Oren. Thank you so much for that wonderful introduction. And we're going to jump right in here and look at the aorta, gallbladder, and kidney, and the when, why, and how we can interrogate these organs with ultrasound. So I'm going to start with a case. And this is a case of a 67-year-old gentleman who's complaining of back pain, radiates to the front of his abdomen slightly. And he's a smoker. He has a herniated disc, so he suffers from chronic back pain and is a chronic opioid user that he's trying to taper down. But this back pain seems much more severe. And in fact, his brother has kidney stones. And so he's come in because he's pretty sure he has a kidney stone. His blood pressure is 120/70, which he says is great for him because he's usually 160/90. His pulse is a little tacky at 105. He's afebrile, and his oxygen saturation is 93%, which he also says is good for him because he's a 50-pack-year smoker. So let's look at the aorta with the ultrasound. And we're going to go through a quick demo here. So this is Dr. Frankel demonstrating with the probe how to do an aortic exam. So with the probe in transverse, marker towards the patient's right, he starts at the xiphoid process and he identifies the spine, which is that white area which casts a shadow. And immediately anterior to that, you see a pulsatile, thick-walled, non-compressible mass, which bifurcates right there into the iliac vessels. So this exam only takes a minute, sometimes a few more minutes if it's challenging, but essentially a very easy exam to complete. So when we look at the aorta in our patient, and a shout out to my colleague in northern BC who sent this clip.
This is such a terrifying scan.
So we can appreciate the spine, which is that bright white line, and I'm hoping everybody can appreciate that there is a large aortic mass, which is about 10 centimeters anterior to the spine.
A rule of thumb I go by: if the aorta is bigger than the spine, it's a huge problem.
Yeah. So I wanted to make a few important points about when you're examining the aorta. You want to measure outer wall to outer wall, which is white to white. And you want to make sure, if you're going to measure the aorta, that that's exactly what you're doing. So you need to landmark the spine. So if we look at this clip of the aorta once again, we can see that there is an interior lumen. So that red circle is the interior lumen, but the aorta is the white to white area, which is the vertical line, which is about 10 centimeters. And I've also highlighted the spine. So, you know, in this case, in a gentleman who's slightly hypotensive, he has back abdominal pain. I don't know about you, Oren, but sometimes I have difficulty getting my specialists to believe me. But in this case, you can send them a picture. You can send this clip to your vascular surgeon, or you can send it to your transfer physician, as I would need to do. And basically, this patient's presented, and within 5 minutes, I've got them transferred to where they need to be, which is not my rural emergency department. And I don't know about you, Oren, but I think even if you had a CT scan down the road or down the hall, if this was the image you were getting, they might be interested in going directly to surgery.
Yeah, I would think this patient should go straight to the operating room. And you know, the differential, as the patient walked in, he was leading you down, I've got kidney stones, maybe I have a disc in my back, and you know, lazy without looking, like there could be a real delay here. And that blood pressure was a bit ominous that you mentioned. You know, it sounded normal, but it was actually low for this patient. So a relative hypotension and not really in the shock. Once they're in the shock phase, it's already pretty late. So an aorta this big with a blood pressure that's dropping is, you know, to the OR ASAP.
I'm going to show you another clip. And this is something you're more likely to see. So this is scanning the aorta from the xiphoid down to the bifurcation, which happens just past it there. And once again, you can see the bright white line of the spine. And immediately anterior to it is a thick-walled, non-compressible structure, which is also pulsatile. Although pulsatility is not one of the characteristics we necessarily look for, because the IVC is right next to the aorta. So sometimes the IVC will be pulsatile as well. But the IVC is very compressible. Notice how flat it is right there, whereas the aorta is largely non-compressible. So highlighting some of those important points I mentioned, I've put a white bar right where the spine is. You want to make sure that you measure the vessel that's immediately anterior to it. There's a bunch of vessels anterior to the aorta. In particular, there's the superior mesenteric artery, which runs parallel to the aorta. And, you know, if they have a dilated aorta, their superior mesenteric artery might also be slightly dilated, but it would be a grave error to be measuring that instead of your aorta. So make sure you measure the vessel anterior to the spine. And make sure you measure white to white. With your Clarius app, there's a tools section. It's very easy to measure the diameter of the aorta. And in this case, it's about 3.2 centimeters, which is slightly above normal, but nothing you'd get terribly excited about. Okay, one final note, to screen or not to screen. I will remind people that 15% of AAAs present with rupture, and the mortality for that is 50 to 80%. With that in mind, the American Vascular Society, as well as the Canadian Family Physician Society, and I'm sure many societies around the world, have recommended that you screen all men over the age of 55 and all smokers over the age of 50. And you can do this once a year in your office, or if you see somebody in the emergency room and you've got the ultrasound on to look at another organ, it might be prudent to also look at their abdomen, on their abdominal aorta. So if you're over the age of 40, I hope you would recognize at least some of these people, or hopefully perhaps everyone would recognize Lucille Ball, a great comedian in her era. John Ritter was on Three's Company, and Alan Thicke is a Canadian comedian. All three of these people unfortunately died of aortic dissection.
And you'll see frequently dissection too. We're not really covering it, but as you're going into the abdominal aorta, you'll see the type B dissections as well, almost as easily as you can see aneurysms show up.
Indeed. So if I had a comedian in my practice, I might also consider screening them. However, that's just an association here.
Yeah, separate risk factor.
Yeah. Second case presents almost exactly the same way. Back pain radiating a little bit round to the front. This woman is 47 years old, and she has had back pain that she thinks is related to meals. She's tried some antacids and some constipation meds, both of which seem to help a little bit. And last night she had a severe episode of right back pain radiating round to the front. She did take some of her husband's pantoprazole, his PPI, proton pump inhibitor, and she thinks maybe that was effective as well. So she would just like a prescription for a PPI. So once again, in this case, I would want to look at the aorta, the gallbladder, and the kidney. We just went through how to look at the aorta. So now we're going to go through a how-to of how to look at the gallbladder. And with the probe in sagittal section, so that's up and down, marker towards the patient's head. You can start in the midline and then move over towards the patient's right, towards the hepatic margin. And what you're looking for is the portal vein. So the portal vein has an echogenic wall, kind of like an artery. And the reason for that is it carries a lot of fatty material from the intestine. So it has that thick walled appearance. And right next to it, you'll see a saccular structure, which Dr. Frankel's sweeping through right now. And that saccular structure is your gallbladder. And if you're wondering if you've got the right vessel, you can throw on some color. And with the color, the portal vein will light up, as you can see there. But the gallbladder will not light up because it's not a vascular structure. And in between the gallbladder and the portal vein, you can sometimes see the medial longitudinal fasciculus, which is that white line that connects the portal vein to the gallbladder.
Just right here. I think it's worth pointing out also the normal gallbladder has a thin wall. It's generally completely black, full of normal bile. There's no echogenicity, nothing sparkling or shining. And it doesn't hurt when you push on it, right? So you can really kind of direct the patient and make sure that it's not tender.
Yeah, absolutely. And it's also good, as with any type of ultrasound, to sweep through in two planes as you're doing here. So you sweep through kind of in a longitudinal plane and then also in a transverse plane. So let's get back to our case. In this particular case, this woman had 2 gallstones. So I'm hoping you can appreciate that there is a echogenic mass in the neck of the gallbladder, and it throws a shadow. So a black stripe is coming off that white area. And towards the end of the clip there, you can also see one at the fundus of the gallbladder. So a white band that is throwing a shadow distally.
Yeah, they look like little comets, and it's kind of like bone shadowing. So the ultrasound hits the calcium in the stone and blocks any sound from going through, so you can't see behind it.
You will occasionally see white areas within the gallbladder, which are polyps, but polyps don't shadow. So that's how you tell one from the other. As well, polyps are non-tender. So you wouldn't have tenderness if someone only had polyps.
And these stones in the neck down here, it's so important to look at the neck, because those are the ones that really cause trouble and block up the gallbladder. Ones up high don't seem to cause as much trouble, but when they get stuck, that's the one that kind of leads you down the pathway to cholecystitis.
And those ones in the fundus will often move. So it can be quite entertaining to move the patient while they're getting their ultrasound, and they can see their stones move as well. This is a second clip of a gallbladder, and perhaps a little more obvious. You can see several stones casting shadows.
There's a couple here.
And in this patient, you can also recognize a thickened gallbladder wall. So a normal gallbladder wall is about 3 millimeters. But in the context of, someone who's got right upper quadrant pain and gallstones, if they have a gallbladder wall that's greater than 3 millimeters, in this case it's about 5 millimeters, then that's cholecystitis. And if they're even more sick, you'll see a bit of fluid around the gallbladder, which is pericholic fluid.
Yeah, and the Murphy's is really also, the sonographic Murphy's is really the highest specificity sign of cholecystitis. So, and ultrasound really enables that, rather than guessing, are you pushing on the gallbladder or not, really identifying this is the point of maximal tenderness with the ultrasound, and guiding that examination finding is highly specific.
Yeah, it's nice to put pressure and see the ultrasound and that be the point of maximal tenderness as well. The sonographic Murphy's. And this is an arrow just pointing to that thickened gallbladder wall. I wanted to give another little tips and tricks, because sometimes people are so tender that you can't actually examine and do a Murphy's with the ultrasound. Or perhaps they have a lot of gas and you're just having trouble finding the gallbladder. You can use this transhepatic view. So this is using the liver as an acoustic window, and putting your probe as in the diagram there, or you can put it a little more sagittal. You can even go up between the ribs. And once again, you'll be able to see that portal vein and the gallbladder. And I've highlighted it here for you. And this is what we call an exclamation sign. So the portal vein is the dot, and the gallbladder is the dash that makes the exclamation sign. And that's just another way, along with putting on color, to identify that you're looking at the correct structures. One final case presents exactly the same way. My back hurts, it's radiating to the front. And in this case, this is a 42-year-old gentleman. He's had back pain for a month, but what brings him into the emergency room is he's now got urinary symptoms. So he's got dysuria, urgency, frequency, and his urine is also positive with nitrites and leukocytes and blood. So kind of a slam dunk for a UTI. And with the back pain, you might think of pyelonephritis, although he has no fever. So once again, I would want to look at his gallbladder, his aorta, and his kidney. So a how-to of how to look at the kidney, or to do a renal ultrasound. And if you do fast exams for trauma, this is very similar. You're going to hold the probe in sagittal section, or up and down with the marker towards the patient's head. And you want to get quite posterior. The kidney is a posterior structure. And put your fingers right on the bed, holding the probe gently in your palm. If you draw a line from the xiphoid down to the bed, that's about where you'll find your kidney. And looking at the other side, it's exactly the same. It is nestled right underneath the spleen. So if you drop a line from the xiphoid down to the bed, sometimes you might need to move a little more superior towards the head, and you will identify the kidney. Now, looking at a normal kidney there, we're going to go back over to the right side. You should see the cortex and then some papilla, which are those little pyramidal shaped black areas. Then there's the calyces, which is white, and you won't even really see the renal pelvis in a normal kidney.
I'm usually just looking for the nice, white, bright collecting system as normal.
Yeah, excellent. So in this case, we put the probe on in the left upper quadrant where he was experiencing some CVA tenderness. And you can see the papilla here are quite visible. So they're very dilated. And then the renal pelvis is also dilated. And it looks quite a bit different from the normal ultrasound that we were just looking at.
Yeah, we call it, in Canada here, we call it like the bear claw, right? But we were saying, you know, internationally, we're not sure if everyone has bears. So whatever your creature of choice with a paw or a claw is, tiger, kangaroo, whatever you want to do it.
And so this is on the left side. If we went and looked on the right side, hopefully you can appreciate that this is, in addition, you might appreciate that my probe's upside down, but you can appreciate that you can see the calyces really nicely. There's that white area instead of a big black bear's paw.
And I think you bring up a really good point. You know, in emergency medicine, I scan every patient with pyelonephritis to look for obstruction, because I feel like those patients are really high risk of clinical deterioration with antibiotics if they don't get a procedure to relieve the pressure. They basically have pus under pressure in their kidney, and the antibiotics are not enough. And those are patients who are they're like young and healthy, and they end up going into septic shock with bacteremia if we don't address the underlying cause of obstruction. And it's easy to catch and easy to effectively, you know, get them to the help they need, but it's also easy to miss.
If you didn't have ultrasound, you would, I think, treat this patient as a pyelonephritis, and he might come back very sick. In this particular case, he was referred to the urologist and had a large stone removed the next day. So just a little schematic. You can see the stone within the ureter, and that causes a dilatation of the calyces and the papillae.
And we'll see some of these stones in the kidney parenchyma too. You know, they might cause pain, but they generally don't cause a significant hydronephrosis, and that's harder to pick up on point of care ultrasound. So it's really those proximal stones that will cause the trouble.
I did want to bring up one more point with regards to renal ultrasound. Once you start doing a lot of these, you will start to see simple renal cysts. This is a picture of my own kidney. I was doing a virtual coaching session with my colleague who provided the aortic clip, and I was showing her, you know, where to put the probe, and I was kind of surprised to see I had a cyst myself. It's only about 2 centimeters large, so we don't really get excited till they're about 4 centimeters, but they are common and they will increase with age. So you will certainly see them in your practice once you start looking at kidneys.
Would you call it, I think I would call it maybe the most common incidentaloma that we see on point of care ultrasound?
Yes, absolutely. And if they're under 4 centimeters, I don't think necessarily, you know, you need to get excited about that, but you may want to get a high level ultrasound just to check it out. And you can see here my calyces look normal. So I don't have a dark dilated renal pelvis. And that simple cyst is located within the cortex of the kidney. So hot off the press here, in the Annals of Vascular Surgery, there was this interesting article from February of this year showing an association of abdominal aortic aneurysm and simple renal cysts. You're 3 times more likely to have renal cysts if you have an abdominal aortic aneurysm. So certainly in people who are over the age of 50, who I see a simple renal cyst, I will also look now at their aorta.
I think it's only more research for this abdominal triple scan that you're kind of advocating, you know, back pain, flank pain, just scan all 3, kidneys, gallbladder, aorta, and, you know, like just seeing the cyst, or, you know, it's going to make me do it more and more.
Well, you're in the area, and sometimes, you know, putting the gel on is what takes the most time, and turning on the machine. So while you're there, you might as well. And in conclusion, I'm just going to go through 5 ways ultrasound has helped my practice. As we have shown here, it's often a faster diagnosis, especially if it's a large aorta or something obvious. A more accurate diagnosis, so I'm not left wondering, well, it could be an aorta, or it could be a gallbladder, it could be a kidney stone. And as a result of that, I'm able to get patients more rapid treatment. And we're certainly seeing this in rural and remote areas where it's really important to make the right diagnosis and get someone to where they need to be, or to be able to reassure them and not waste unnecessary transport. It leads to better patient care. And the most important one is, you know, increased patient confidence and satisfaction. And, you know, my confidence and my work satisfaction has improved immensely. So mid-career, I picked up the ultrasound, and it's really enhanced how I feel about practicing medicine, because I just feel more excited to be able to make these diagnoses.
Yeah, I would agree, kind of up and above our clinical exam, right? We're so much more confident now leaving the bedside with a diagnosis than, oh, I guess I need to do some investigations and it's still this lingering question about what the answer is. I find I leave the bedside a lot more with an answer and confidently. So great. Well, thanks so much, Virginia. You know, one of the things I really love about ultrasound at the point of care is how it really enables this really broad approach to the clinical exam, like I was alluding to in the beginning, that's above and beyond what we can do with our regular tools. And I really like, with a single probe, you can kind of scan multiple parts of the body at once. And I was going to demo here on our live model how, you know, with the probe, how quick it is to really get kind of like when we were doing a regular screening exam, a physical exam, I can assess multiple different organ systems at once. So I can use the probe and this feature in the app of auto select, where I can put the probe where I want it, and it will switch to the preset I need. So starting with a cardiac scan, really looking and interrogating for a pericardial effusion, chamber size and function. And from here, I can take a look now at the patient's lungs. Looking for any sign of fluid, consolidation. From here, I can come over to the abdomen. Maybe I need to scan for free fluid or interrogate the kidney, as Dr. Robinson was showing us. Come over into the anterior abdomen. Scan the gallbladder. or come over and do an aorta scan. It's part of my abdominal triple scan. Nice and thin. And maybe especially in the primary care setting, I wanted to look for urinary retention, pop down onto the bladder. And as it goes into bladder preset, I can check for post-void residual or signs of urinary retention. With my bladder preset, it will have the calculations built in. We have a few minutes left. We have some time. I know there's a lot of questions in the Q&A, so please put your questions. We'll save some time. We're going to hand it back to Janez to take it home, and then we'll save some time for sure to address all your questions and really go over and get you all the answers that you guys are looking for.
Thank you, Dr. Frankel and Jake, for the live demo. And thank you, Dr. Robinson, for sharing your ultrasound techniques and helping hone our image interpretation and diagnostic skills. Before we start a live Q&A session, I'd like to take a minute to tell you a bit more about the Clarius C3HD multipurpose microconvex wireless scanner that you saw in the live demo. Just like our full family of products that include linear, phased array, and endocavity scanners, the Clarius C3 delivers the highest definition ultrasound imaging in a wireless, affordable, and easy to use system. Clarius is unrivaled for image quality in a handheld ultrasound. It shows you the fine details you need to quickly investigate an area of concern and make a confident diagnosis on your patient's first visit to expedite the right treatment plan. Each scanner is designed with 8 beamformers that deliver the image quality only found in traditional systems, but at a fraction of the cost. Artificial intelligence replaces complex knobs and buttons, making our scanners fast and easy to use and learn. Clarius is also wireless, freeing up space with zero footprint for high portability to scan patients where they are. You get free movement with no wires getting in the way or infecting your sterile area. And with no wires, it makes it so much easier also to clean and disinfect. Only Clarius scanners come with a free ecosystem that includes free apps for your iOS and Android devices with free updates, unlimited cloud storage to capture and manage your exams, and for unlimited users at no additional cost. Clarius Live delivers one-click telemedicine if you need to share live scanning with a colleague for a second opinion. And with no subscription fees, Clarius HD scanners are ultra affordable. And coming very, very soon, we'll be announcing the release of Clarius Ultrasound App 8.0 that includes dozens of new features, including advanced innovations made possible by machine learning and artificial intelligence. We're particularly excited about the auto preset AI, which you saw in action today, that recognizes anatomy at a macro level and selects the appropriate preset to automatically optimize imaging in real time. So now, before we begin our live Q&A with Dr. Robinson and Dr. Frankel, I'd like to take a minute to invite you to learn more. So before we open up the floor to questions, here's a quick question for you. Would you like more information about Clarius HD scanners? And you can go ahead and select any of the options here that you see. We can offer you quote and pricing, as this product is available in over 90 countries, and we have so many of you joining us here today. We can talk to you about availability and pricing in your local region. If you'd like to speak to one of our ultrasound experts, because you've got some questions about how to use our wireless scanners, we're happy to set up a call for you. If you'd like to book a live Clarius demo so that you can see the new auto preset feature, but all of the features really in action, we'd be happy to schedule something that's about 30 minutes long so you get a little bit better look into the product and learn how to use it. If you'd like to discuss features or compare it to other systems, we'd be happy to do that for you as well. And we've got a number of Clarius classroom tutorial videos available. So if you select that, we'll be sure to send you a link to access many, many more video tutorials. I'm going to give you 5 more seconds here to weigh in. Again, please go ahead and select any option that you like. 4, 3, 2, 1. Oh my goodness, so many more people voting. Let's give you 2 more seconds. 2, 1. All right, we're going to go ahead and close the poll. If you didn't get a chance to answer the poll, please go ahead and visit our website at clarius.com. and we'd be happy to set up a time to book any demo or discovery call with you that you need, no problem. All right, we want to do one more thing before we go to the live Q&A, which is invite you to our next month's webinar, POCUS for COVID and Beyond, Diagnosing Lung, Cardiac, and Thromboembolic Diseases with internal medicine physician and ultrasound educator, Dr. Shane Arishenkoff. He'll teach us how to diagnose lung, cardiac, and DVT pathology. And he'll go way beyond B-lines and teaching us both basic and advanced POCUS applications for confidently diagnosing patients suffering from COVID and other cardiac and pulmonary diseases, including deep dive into pleural line abnormalities, focused cardiac scanning, and DVTs. So go ahead and save your seat with this poll. And what we'll do is we'll send you your registration confirmation email in the coming days. I'll give you 3 more seconds to save your seat. 2, 1. All right, we'll go ahead and close this poll. Again, you'll have many more opportunities to register if you didn't get a chance to answer the poll just now. Now on to our live Q&A session. I'd like to welcome back Dr. Robinson and Dr. Frankel. Please use the questions icon in the menu bar to ask questions of our doctors. I do want to let everyone know that in the coming days, we'll email you a recording of today's session, as well as a PDF copy of today's presentation. Now on to your questions. Dr. Frankel, can I invite you to moderate our Q&A?
Yeah, I'd be happy to. There's a lot of really great questions here, Virginia. So let's go and dive in. First question was, how long did it take you to become comfortable using ultrasound?
Yeah, that's a really good question. Like many people, I took a course in ultrasound and then went back and really didn't use it very much in my practice. So my skills were lost and I had to go take another course. But eventually you have a finding that is very impressive and changes your practice. And then you kind of get serious about ultrasound. And so you start practicing and develop some certification and undergo your 50 observed scans. And within about 3 to 6 months of doing those things, you're quite comfortable.
And that's what you did here in Canada. I guess our training was more integrated into our clinical education, some basic indications, but then, it can be a self-taught thing too, where you kind of choose particular applications to learn more, and then you're still getting the regular clinical flow, like getting the radiology performed ultrasounds or CTs or x-rays, whatever it is on the specific organ, and then accumulating your own personal library. So at some point you feel comfortable saying this is cholecystitis or cholelithiasis or a normal gallbladder after you've done 25, 50 scans, that you kind of got the official answer down the line. Right?
That's a great way to do it. If you're, mid-career, you weren't exposed to ultrasound in medical school or residency. And unless you choose to go back and do a fellowship, you need to use some of these other ways to educate yourself.
Yeah, you kind of reach for whatever educational things you can. Great. There were a lot of questions around, not surprisingly, the association, the paper associating the renal cysts and AAAs. People want to know more. So I think people are curious, from what I can, combine a few of the questions together, if it goes both ways, right? Like risk of AAA predicting renal cysts, but if you see renal cysts, does it predict AAAs?
So this paper did not address that. So they took a cohort of people with aortic aneurysms and looked at, did they have renal cysts? And then a cohort of people who didn't have aneurysm and look at whether they had renal cysts. So the answer going the other way was not in this paper. We don't have evidence that if you see a simple renal cyst, that they are 3 times more likely to have a AAA. It doesn't work that way. Mm-hmm. I just happen to feel like if there is an association and it's easy for me to look and it's such a great, important find, why wouldn't I go for it? But the evidence hasn't been brought out for going renal cyst to aortic aneurysm.
And I guess, for us, if we're catching the renal cysts, we're already scanning the kidney for a reason, probably, right? Flank pain, abdominal pain, hematuria, maybe something like that. And so it's not far. We're not just kind of pulling it out of nowhere to do the scan of the aorta. We're already there, and clinically it may also make sense. I guess the concern is you're catching more of these small AAAs, the 3 centimeter AAAs that maybe nobody wanted to know about. But all the evidence that I've read about screening for AAAs still recommends that you're saving lives by doing it in the net. More people may get procedures, but if you're doing it over a large population, you're ultimately saving people's lives and saving morbidity associated with AAA rupture.
Yeah, absolutely. And that's the goal, I think, from the American Vascular Society, why they recommend screening. And
maybe they want to just stay in business.
Maybe that too.
Yeah. This is maybe a tough question, but we'll hear your perspective on, can non-radiologists bill for point of care ultrasound, speaking of the business side of medicine?
So here in British Columbia, I cannot bill for ultrasound. I would like to actually develop a workflow where my radiologist could bill for my ultrasound. Because I would like, to develop that relationship with my radiologist, so I could call them up like I do with an X-ray and say, hey, this looks a bit funny to me. What do you think? Obviously, in other jurisdictions, they are able to bill, and that's worked out very nicely for them. To me, the patient and provider satisfaction that comes with doing ultrasound is enough for me.
Yeah, and I trained in the US, and I know in the US, practitioners can bill for point of care ultrasound. There are some stipulations that images need to be archived and recorded somewhere, and it's integrated into the patient record. I don't know exactly the specifics in Europe and Asia and Australia in terms of how the billing works. But, yeah, like you said, there's various other approaches and ways that you can feel compensated with satisfaction even without finances.
Not that I would turn it down. I would probably accept the remuneration if it was offered to me.
Right. Okay, so here are a few questions about gallbladder. Let me see if I can combine them. So do you have any tricks or tips on kind of getting harder to image gallbladders?
Yeah, absolutely. So I touched on it a little bit. Often, the gallbladders that you want to image are also, the abdomens that are difficult to image. And there might be a lot of bowel gas or soft tissue. And so I think trying from that right upper quadrant view and, aiming your beam towards the ultrasound, towards the gallbladder, can be one way to pick a gallbladder up that you might be having difficulty in the normal, what we would call X-7 or xiphoid -7. So you're, as we showed in the video, you're holding it in sagittal section and moving towards the patient's right. You can certainly try that, but I kind of, just to find where the gallbladder is, I like that transhepatic view.
I would add, I'm pretty impatient when I'm seeing patients. And so I will try kind of what we were showing. If I don't see it on a first pass, either with bowel gas, I often have the patient take a deep breath and hold it in if they can. Brings everything kind of down and pushes the liver and gallbladder out. So maybe I can see it under the ribs. And then if that doesn't work, I quickly turn the patient onto their left side. And the left lateral D-cube gets the bowel gas out of the way a lot of the time. It's how most of the sonographers will do the scan. And especially in my more American BMI population where I trained, that was an important maneuver to get better scans. And there's a couple comments here in the Q&A that most of the scans on gallbladder on patients who have recently eaten and their gallbladders are hard to find. Yeah, I've definitely had that experience too. And that's a good sign. It means they don't have gallbladder pathology. They can eat and their gallbladder squeezes down. Yeah,
that left lateral decubitus is a really good trick. And I guess I do it so frequently, I sometimes forget that that's what I do.
That's a move. Yeah, it's a good move.
But it's a great move.
How often, we didn't really touch on this in the content, but I really like the comment here. There's a practical point for primary care physicians that the calculation of residual urine is very practical and helps dictate management. And we just showed it in the demo, but is that a scan you're doing a lot, like checking people for urinary retention?
I will do it occasionally.
Mm-hmm.
It's certainly an impressive exam when you find it. I did have a really interesting case that someone sent me, for an abdominal mass in this elderly patient. And I was told, can you admit him for palliation? They've obviously got this large mass and, they're not doing well. And I went to see this patient and threw the ultrasound on, and this big black, mass came into view, and it was very clear that this person was in urinary retention. And obviously I cured them of their tumor within minutes. I was, it's not often you get to cure cancer within a few minutes. So that was
that's amazing. You just drained the tumor.
I just drained the tumor and worked out well.
And it does touch on what the scan that you did show of finding urinary retention with a bladder. The patient just went to the washroom, they have a bladder full of urine, and then you pop up and you see the kidneys dilated too, right? We focused on stones with hydronephrosis, but you can get downstream obstruction anywhere, either from a stricture or prostate or, a malignancy blocking the urine, and you can get bilateral hydronephrosis associated with it. It helps you kind of nail the diagnosis. So when I see urinary retention, I see a bladder full and bilateral hydro, I'm concerned, okay, there's something really blocking the flow. And this has been going on for a while and they need help soon. Let's see. What are some of this kind of touches on, what are some of the other applications for point of care ultrasound in primary care that you have found?
So, we've mentioned that there really are lots. I think the MSK, looking at rotator cuffs, joints, hips, bursitis, can have a lot of value in primary care. But also echoes, is that heart squeezing well or is it not? B-lines, trying to figure out why this patient is got so much edema can be helpful. The aortic screen. There's certainly lots of applications. First trimester ultrasound, another one. The patient is bleeding in the first trimester. To be able to put your ultrasound on and see that fetal heart, what a reassuring, wonderful thing that is for your patient who's really concerned they're miscarrying.
Mm-hmm. Mm-hmm. Yeah, when you're talking about patient satisfaction, they're really happy to hear that. And especially, we know, because we're working with a lot of rural physicians here up in BC, but the concern about ectopic pregnancies and things, if you don't have a way to tell that there's an intrauterine pregnancy and someone's bleeding first trimester, it can be a really concerning, and people are traveling like significant distances to get those scans. And, for all kinds of different imaging technology. Yeah,
our friends in Haida Gwaii, it's a full day ferry ride. So it's 3 days to get your ultrasound.
Yeah, you can imagine it's not going to happen very often. Yeah, let's see. We covered the cysts. Are you concerned about medical legal liability?
I think it's really important to be prudent. So I kind of went over how I became confident using ultrasound and making sure I had those 50 observed scans, and I sent everybody for formal or high-level ultrasound in addition to doing my own. And I think if you're honest with patients and honest with yourself, and you're competent in your skills, and you call it as you see it, then I don't think there's reason to have medical legal fears. And as you know, all of the successful suits have been related to people not using ultrasound, not people using ultrasound. So failure to use ultrasound will get you into more trouble than not, I think. But
yeah, that's what I understand the cases in emergency medicine, at least in the US, that cases gone to adjudication on ruptured AAAs because it's almost essentially considered standard of care, and there was an ultrasound nearby that wasn't used. Delayed a diagnosis, we know increases morbidity and mortality significantly, and it was felt, the practitioner should have scanned. And we see how quick and easy the scan is to do, right? You're gonna be kind of held to that standard. Absolutely. So there's a lot of great comments on some keen users. I like this. Ultrasound is my third hand now in my general practice. That's a pretty great. I think we may use that one, Dr. Camilleri. We might have to take that one, third hand. I certainly, I call my stethoscope my placebo scope now, and I wear it as a showpiece. I don't know how you feel about that, Dr. Robinson, but.
Yeah, absolutely. I put it on. It's part of my costume, and sometimes I even use it.
Yeah. There's a comment here. I'm going to answer this one about, thoughts about the extra time it takes to perform POCUS in a busy ED. I work in pretty high volume urban emergency departments here in Vancouver, and I work in one of the busiest ERs in Canada. Just did a shift last night, and I probably scan about 20% of my patients, largely because I find it really expedites my disposition of those patients. I get the diagnoses really fast, and I know I have cognitive closure. So even though I know because of our workflows, there are still some challenges, I still need to get radiology performed, imaging sometimes to get, especially for my consultants and for downstream management. I know exactly what's going on with patients as I leave the room, and it really helps kind of laser focus how their disposition is. And the data really supports also a decreased length of stays for using point of care ultrasound, but there is a learning curve. No one can deny that there's a learning curve. So you really have to put in the time up front. It's like a change in habits, right? You have to kind of create the habit of doing point of care ultrasound and supplementing or replacing parts of your physical exam with it in order to get the downstream benefits. But now having done it for 5+, 8+ years, it really is second nature. And especially with the handhelds, it's so easy. I don't have to go chase a cart down or run and get the thing. I just fire it up, scan the patient. It's ready as I walk in. And I instead of laying hands on the patient, which really doesn't help my diagnostic abilities that much, I just ultrasound. And for us in emergency, really intra-abdominal disasters, not just AAAs, but seeing pelvic anatomy, seeing appendicitis, renal pathology, gallbladder pathology, it really kind of helps narrow it all down. So, I'm kind of maybe not the right one to ask, but it's really transformative to our practice.
I feel the same way. It's a skill like any other skill that you learn in your practice, whether that's central lines or thoracentesis and you have to put the time in. But once you put the time in, the payback is huge. First trimester bleeding, you see an intrauterine pregnancy in 3 minutes, and from an emergency perspective, you're done, and that patient can leave your department. So it really helps workflow.
Archiving images, how do you record or share your images?
That is a great question, and one that I'm super passionate about. So I use the Clarius Live a lot for sharing images. It works really well. You can also, share images through Zoom or other means. And archiving images, I think, is very important. And we don't have, in my jurisdiction, a great way to do that. And we're working to do that. But I can archive my images on the Clarius cloud. And I think it's important to do so.
Yeah, the cloud makes it, almost brainless. You just, as you're closing, you just hit end exam and it fires it automatically, and then you can retrieve it whenever you want later, or really easily share with your consultants or colleagues about teaching cases. So it really makes that workflow so much easier than the carts that we trained on even just a few years ago.
Thank you so much, Dr. Robinson. Thank you so much, Dr. Frankel, for your passion around POCUS and all of your great insights today. We've now reached the top of the hour. If we didn't get to your question, and there were dozens, we will absolutely follow up with you by email in the coming week. A reminder that you will all receive a copy of the PowerPoint slides in PDF format, as well as a recording from today's webinar by email in the coming days. We hope to see you again next month with Dr. Frankel and Dr. Arishamkov for the live webinar, POCUS for COVID and Beyond, Diagnosing Lung, Cardiac, and Thromboembolic Diseases. In the meantime, have a wonderful rest of your day. Thank you.
Thanks, everyone.